Welcome back to Talking Ketamine. This is episode 19, and today we're tackling a really critical topic. Major depressive disorder, MDD. It touches so many lives, something like 280 million people globally.
It's staggering.
It really is. It's incredibly debilitating. But
Mm-hmm.
what happens when the standard treatments just don't seem to work? That's where we hit this really profound challenge of treatment-resistant depression, or TRD.
Mm-hmm.
Now, you've probably heard about ketamine. It's just gotten a lot of attention lately. It's a rapid-acting agent, shows incredible promise for TRD, even for acute suicidality.
Absolutely.
But often, the conversation seems to focus on intravenous IV administration,
Yeah.
usually in a hospital or clinic setting.
Right, the typical infusion setup.
Exactly. So today, we're going to shift our focus. We're going to explore a novel, maybe a far more accessible form of ketamine therapy, something that could really change the game for long-term treatment.
Precisely. And that's so important because finding practical long-term solutions for something as persistent as TRD, well, we face some significant hurdles.
Yeah.
Existing treatments, they have clear limitations. And even ketamine, with its remarkably rapid effects, well, those effects can be transient. They might only last days to weeks.
Right.
So our mission today really is to explore how this unique approach to ketamine delivery might tackle those challenges head on and maybe open up some entirely new doors for sustained treatment, better quality of life.
Okay, and guiding us today, we're leaning heavily on a really fascinating source. It's a unique case of very low-dose subcutaneous ketamine use, maintenance option of ketamine for treatment-resistant depression.
Mm-hmm.
It's authored by Adam T. Can, Daniel F. Hermans, and Jim Lagopoulos. First published in Clinical Case Reports back in December 2022. It's quite a story.
It really is.
So let's get right into it.
Okay.
Let's start at the beginning. Treatment-resistant depression. It sounds, well, incredibly daunting. Can you maybe paint a picture of what that really means for someone living with it? And how do doctors actually define it? What's the struggle there?
It is absolutely daunting. I mean, for patients, it means you're enduring these severe depressive symptoms even after trying really hard to find relief. Clinically, we typically define TRD as a major depressive episode that hasn't responded effectively after at least 2 adequate trials of antidepressant monotherapy.
Okay, 2 trials. And adequate means?
Adequate means the right dose for the right amount of time. Usually that's a minimum of, say, 8 to 12 weeks for each medication trial.
Wow, okay.
So we're talking about someone who has genuinely tried standard approaches, often for many, many months, and is still suffering, still dealing with significant ongoing depression.
Yeah.
And the impact is huge, not just quality of life, which is obviously primary, but economically too. The medical expenses linked to TRD can be something like 20 times higher than for depression that does respond to therapy.
20 times, that's incredible.
It is. And the standard treatments like psychotherapy and the usual antidepressant medications, the ones targeting the monoamine system mostly, they only really alleviate symptoms in maybe 30 to 50% of cases. Either the response isn't enough or people just can't tolerate the side effects.
Right.
And even if you optimize things, add other drugs, there's still this persistent group, maybe 15% of patients, who experience substantial, really debilitating depression.
That really highlights the need, doesn't it? The desperate need for something more effective.
Yeah.
We sometimes hear about other advanced options, things like electroconvulsive therapy, ECT, or transcranial magnetic stimulation, TMS. Why aren't those the go-to solution for everyone in this situation?
That's a really good question. And they are important tools. They can be very effective for some people,
Okay.
but they're not suitable for everyone. Take ECT, for example. Often quite effective, yes, but it can come with significant side effects. Things like short-term, sometimes even long-term memory loss. And that's a major concern for a lot of patients.
Understandably, yeah.
And TMS, while it's generally better tolerated, it also has specific criteria. And it's certainly not a guaranteed fix for everyone either. Each person's unique medical history, their specific conditions, even just their preferences. It all plays a big role in figuring out the best path.
Right.
And that leaves this critical gap for many patients, a gap where maybe new approaches like delivering ketamine differently could finally make a difference.
Okay, let's talk about ketamine itself then. It has this reputation now as a breakthrough, but like you said, it's not a new drug at all.
Not at all.
Can you give us a bit of background, its history, and what makes it so unique for treating depression specifically?
Yeah, absolutely. It has a remarkable history, really, over 50 years. It started as a rapid-acting general anesthetic and a short-acting analgesic. So basically, used to put people to sleep for surgery and relieve pain for decades. And it has a very well-established safety profile in those kinds of acute settings.
Mhm.
But more recently, its powerful properties as a non-competitive NMDA receptor antagonist. That means it works on a completely different brain pathway than traditional antidepressants. That's what's led to its exciting use in treating various psychiatric illnesses,
Yeah.
especially severe depression and suicidality.
Right.
It seems to offer rapid, robust improvement. It essentially helps to sort of reset and restore normalcy to brain pathways that get disrupted by chronic stress.
Okay, here's where it gets really interesting, but if it's so effective, bringing such rapid relief, why hasn't it become more widely available for long-term use? What's been the biggest roadblock? What's the catch?
That really is the core question, isn't it? Despite ketamine's fast action, its antidepressant effects often seem to be, well, transient.
Uh-huh.
They typically last only days to maybe a few weeks, and that transience, that's the main hurdle for using it long-term in psychiatry.
Okay.
So the biggest gaps in our knowledge when we think about using it longitudinally involve figuring out the best dose, the right duration, the frequency of treatment needed for sustained improvement.
Makes sense.
And beyond that, there are potential complications we need to understand better in a chronic context. Things like the risk of cystitis that affects the bladder hepatotoxicity, affecting the liver, maybe neurocognitive changes down the line, and of course, its potential addictive properties.
Right, those are serious considerations.
Exactly. So while it has this long safety record for acute short-term use, the long-term safety for chronic mood disorder treatment, it just hasn't been adequately studied yet. And that's why we need more research before it becomes, a widespread go-to chronic treatment.
And that brings us right to the practicalities. Most of the studies we hear about and the current clinical uses, they primarily involve 5E infusions, right? Often in hospitals or specialized clinics. What makes that specific approach difficult or impractical for long-term widespread use?
Yeah, the practical downsides of IV are pretty significant. First off, it has low feasibility and accessibility. It's expensive, you need specialized equipment, trained medical staff.
Right.
And it's just really impractical for routine, real-world psychiatric settings. I mean, imagine having to go to a special clinic, spend hours there getting an infusion, maybe multiple times a week for who knows how long.
Yeah, that's a huge commitment.
It is. And then there's the IV catheter itself. Placing it requires skill, and it can lead to complications, things like malfunction, thrombosis, infection, painful phlebitis, even extravasation where the medication leaks out of the vein.
Ouch.
Yeah. These issues limit access, and they add significantly to the patient's burden, both physically and, emotionally.
So if the traditional ID method creates such a barrier, what does that mean for patients who are desperately looking for something more manageable, something they can integrate into their daily lives? It really sounds like we need an alternative.
Precisely. We need options that are less burdensome, more integrated, and frankly, accessible to a broader range of people. And this is exactly where the paper we're looking at today offers such, valuable and unique insight.
Okay, so that brings us right to the heart of this source paper. This unique case report exploring the use of very low-dose subcutaneous ketamine as a maintenance option. Expert, can you walk us through the patient's story? Who was this person, and what were they dealing with before they tried this new approach?
Right. So this case report focuses on a 42-year-old man. He had been battling severe treatment-resistant depression for over 15 years.
15 years.
Yeah. And his symptoms were truly debilitating. We're talking profound depressed mood, chronic insomnia, no appetite, just despair, anhedonia, that inability to feel pleasure in anything, crushing fatigue, persistent depressive thoughts, intense anxiety. He'd become socially isolated, found no enjoyment in anything at all. His occupational functioning had significantly declined. He struggled severely with reading, writing, just focusing.
This is incredibly difficult.
It was. He also had a history of suicidal thoughts, though thankfully no actual attempts. But at the time he was admitted for this potential treatment, his depression was profoundly severe. His score on the Montgomery-Åsberg Depression Rating Scale, the MADRS, was 42.
42, and what does that mean contextually?
Well, to put that in perspective, any score over 34 is considered severe depression. So 42 is very severe. His score on the Depression Anxiety Stress Scales, the DAS Depression Subscale, was also very high, at 30.
And he really had tried almost everything before this, hadn't he? It wasn't like he hadn't put in the effort.
Absolutely not. It underscores the severity of his TRD. He'd been under psychiatric care for years, cycled through multiple medications from different classes, tricyclics, MAOIs, SSRIs, SNRIs, even mood stabilizers like lithium and olanzapine.
The whole gamut.
Pretty much.
Yeah.
He had even tried transcranial magnetic stimulation, TMS. And unfortunately, it didn't provide any lasting relief for him. He hadn't undergone ECT because he was worried about the side effects, like memory loss. So this patient really represented that extreme challenge of severe, unyielding depression, a case where nearly every conventional and even some advanced treatments had failed him.
Okay, so given this incredibly long and difficult history, how did they approach the subcutaneous ketamine treatment?
Yeah.
What was the plan? What made it different?
The approach was very careful, very considered, and really quite innovative for the time. The patient received twice-a-week subcutaneous ketamine injections.
So under the skin, like an insulin shot.
Exactly like that. Much simpler than IV. They started him at a very low dose, just 20 milligrams, which worked out to about 0.2 milligrams per kilogram of his body weight.
Okay.
And then over 4 weeks, they gradually titrated that up, increased it slowly to 35 milligrams, or about 0.35 milligrams, twice a week. And this was used as an add-on, an augmentation to the psychiatric meds he was already taking. It wasn't a replacement.
Working alongside his current treatment.
Precisely. The protocol actually allowed for titration up to 0.5 millibiokilogram per week, but they found he had a sustained clinical response at that lower 0.35 millibiokilogram dose. That became his tolerable and effective level.
And they monitored him closely, I assume?
Oh, rigorously. Throughout this initial phase, they monitored his vital signs constantly, used the brief psychiatric rating scale to track symptoms, and did weekly urinalysis just to keep an eye out for any potential side effects, particularly bladder issues.
That sounds like a very measured, very personalized approach. So the big question, after all these careful steps, what happened? Did this unique subcutaneous method finally break through for someone who had suffered for so long?
It did. And the results were genuinely remarkable. From just the second week of treatment, he started experiencing significant improvements in his mood.
The second week. That's fast.
Incredibly fast, especially given his history. He reported feeling happier, his affect was more reactive, meaning his emotions were more appropriately responsive to his environment, which is a huge positive sign in depression. And he just felt clearer in his head. His MER score, remember, it started at a severe 42.
Yeah.
It dramatically dropped to 12. After that initial 4-week course.
12, so out of the severe range completely.
Completely. And his DAS depression score also plummeted from 30 down to 8.
That's amazing. What about side effects with this method?
He reported only mild and transient side effects, things like some sedation, feeling a bit spacey, maybe some dizziness or lethargy, and some dissociative feelings right after the injection. But crucially, these were temporary, and importantly, there were no psychotic symptoms observed during monitoring. That's a critical safety point.
That initial response is just incredibly encouraging, astounding, really, given 15 years of struggle. But, as we talked about earlier, the big challenge with ketamine has often been that transient effect.
Exactly.
So what about long-term? Did the benefits last?
Yeah.
Could this be maintained?
And this is where the case really shines a light on new possibilities. It sort of challenges that common perception of ketamine's effects always being short-lived. After that successful initial 4-week course, the patient understandably expressed a strong desire for ongoing maintenance treatment. He wanted to continue feeling better, but in an outpatient setting, which is vital for quality of life.
Makes perfect sense.
So after a second opinion confirmed how crucial this treatment was for maintaining his improvement, they set him up with subcutaneous ketamine maintenance. Initially, it was every 12 days, because his mood would apparently start to dip a bit around that mark.
Okay, so they tailored the frequency.
They did. Then, to make it even more feasible and sustainable for him long-term, they adjusted the interval to fortnightly so, once every 2 weeks.
And did it work? Did the improvements hold?
The sustained improvements were profound. His MIDI-S score dropped even further during this maintenance period, down to a remarkable 4.
4. That's basically remission, isn't it?
It indicates near complete remission of symptoms. It's fantastic. In fact, his dose was gradually reduced even more, down to just 14 milligrams per fortnight, because the slightly higher dose started making him too sedated as he got better.
Wow.
Throughout this entire time, he was consistently monitored vital signs, general well-being, any psychotic symptoms. And here's the truly significant finding, the real kicker.
Yeah.
At the time this report was submitted, This patient had been taking maintenance subcutaneous ketamine for 4 years.
Or years?
4 years, maintaining a stable mental state, functioning well occupationally, reporting no subjective cognitive decline. This wasn't just a temporary fix, it was sustained well-being. It points to a whole new potential pathway for chronic care.
That is genuinely groundbreaking. 4 years of stability for someone with that level of severe treatment-resistant depression.
Yeah.
It's transformative. So this really brings up an important question for you, the listener. What does this case tell us about why subcutaneous ketamine might hold so much promise? What are the advantages over that more common IV method?
Well, the advantages are really multifaceted, and they directly address those practical hurdles we talked about. First off, subcutaneous administration is significantly less invasive than sticking an IV needle in a vein. That's a huge plus for patient comfort and just willingness to stick with the treatment.
Absolutely. Less medical, less intimidating.
Exactly. It's also dramatically more cost-effective, much more practical, and more affordable. You don't need all the specialized equipment or the highly trained staff that IV administration requires.
Right.
That makes it far more accessible in real-world clinical settings. Think about patients who are financially disadvantaged or live far from specialized clinics. This could potentially open doors for them.
That accessibility point is huge.
It really is. And then there's the pharmacology, which is fascinating too. Subcutaneous use means the drug is absorbed more gradually into the bloodstream compared to an IV, which dumps it right in very quickly. This slower, more controlled uptake, it might actually decrease adverse effects. Because it keeps the concentration in the blood plasma lower at any given moment, it might prevent some of those more intense psychomimetic or sort of mind-altering side effects that can sometimes happen with higher, faster concentrations.
So it's maybe a gentler delivery.
Potentially, yes.
Yeah.
And that could be a key factor in making it more tolerable and sustainable for long-term use. It helps explain how that patient achieved that 4-year success story we just heard about.
So basically it boils down to making this potentially life-changing treatment more accessible, more convenient, maybe even safer or more tolerable for long-term use. Are there other studies, even if they're limited, that back this up? Or is this case report kind of standing alone right now?
It's not entirely alone, although studies specifically on long-term subcutaneous use are still limited, you're right. But there was a recent comprehensive review that looked at 12 different studies on subcutaneous ketamine, both racemic ketamine and esketamine use for depression. And this review included case reports, retrospective studies, clinical investigations, and it showed positive results overall. The side effects were generally transitory, and the effectiveness seemed comparable to IV ketamine in many ways.
That's encouraging.
It is. There was also a randomized trial specifically in older patients that showed promising results with subcutaneous delivery. So while we definitely need more extensive research, absolutely, this single case adds a really crucial and frankly powerful piece to a growing puzzle. It suggests a pathway that really deserves a lot more attention.
Okay, so given all this, looking forward, what do you see as the future for this type of treatment? What's needed to really validate it and potentially bring it into broader practice?
Well, while this single case report gives us excellent clinical insight and it's a truly compelling story, we absolutely need further high-quality, systematic, randomized clinical trials to really validate these outcomes.
Right, the gold standard research.
Exactly. Specifically, we need studies that directly compare subcutaneous delivery with intravenous delivery. Head-to-head studies looking rigorously at efficacy, optimal dosing, the pharmacokinetics, how the drug moves through the body, and, importantly, cost-effectiveness.
Makes sense.
But this case, it really does suggest a significant pathway forward. It offers a glimpse into what could be a very hopeful future for people battling the most persistent, resistant forms of depression.
So just to kind of wrap up our discussion today, this unique case really highlights the potential, doesn't it? The potential for very low-dose subcutaneous ketamine as a tolerable, safe, and maybe most importantly, an effective long-term maintenance option for severe TRD, offering a much more practical, more accessible alternative to the traditional IV route, which, as we've discussed, has so many limitations for chronic care.
Yes, exactly. And I think the major insight here, the real takeaway, might be the power of a personalized, less burdensome approach. This report gives us crucial clues about how we might adapt highly effective treatments, like ketamine, so they aren't just confined to these sterilized, high-cost clinics.
Yeah.
It sort of paints a picture where advanced treatments could become part of more routine, accessible care, especially for those individuals who have quite literally exhausted every other option available to them.
So the final thought to leave you with is this. What might this specific case really suggest about the future of making these advanced mental health treatments more accessible, more personalized? And how could that fundamentally change our understanding and our approach to managing chronic mental health conditions in the long run? Something truly worth thinking about.
Definitely.
Thank you so much for joining us for this exploration today. We hope you've gained some valuable insights.